Hello, it is Tuesday, April 14th, 2020. I'm Jeanne Meserve, a contributor at The Atlantic, and welcome to COVID-19 on the Front Lines, a digital event cast from The Atlantic. We're going to be talking for the next hour or so about the latest science, about the latest treatments, and we'll be looking forward at what we can expect in the weeks and months ahead. Before we get underway, a moment to thank our underwriter PhRMA, who is making these conversations possible. First, let's take a look at where we are right now. As of last night, more than 580,000 Americans had been diagnosed with COVID-19, and over 23,000 had died of COVID-19 related complications. There are some signs of improvement in places like New York. The curve appears to be flattening, but some other hotspots are emerging. And at the moment, 316 million Americans are still under stay-at-home orders. This is an evolving situation, of course. The Atlantic has been moving right along with it, publishing articles like the technology that could free America from quarantine and the coronavirus unique threat to the South. Another article which you may have heard about because it was tweeted about by President Obama is How the Pandemic Will End. It was written by The Atlantic's Ed Yong. Ed joins us here today. You Ed, have another article out this morning called Our Pandemic Summer. So I'm judging from the name of the new article that we aren't going to get over this anytime in the near future. What are you reporting?
Yeah, that's right. I think at the moment, everyone's attention, quite rightly, is on the current wave of the pandemic, which one would hope would peak within the coming weeks or months. But it's clear from every of the experts I spoke to that this is going to be a long-running problem that continues for the rest of the year and possibly even longer as we await a vaccine. That's going to be the real end game that changes how we cope with the pandemic. Until then, we should expect multiple waves of the virus as it recedes and then resurges again. And we will need to steel ourselves medically and psychologically for what is going to be a protracted confrontation with this new virus.
The goal had been to lift the stay-at-home orders by April 30th. Feasible or not?
I think that looks very unlikely, and that's probably because most of the measures that we would need to actually keep the virus in check or to steel ourselves from against future surges are not going to be in place in time. We do not have widespread testing. The US delayed on that, and those delays cost us dearly. We're still not in a position where we can recover the lost ground on testing because of now supply chain problems that are affecting the entire world. Hospitals, as you say, in some places might be going past the curve, but even then, places in different parts of the country will have problems. Hospitals are encountering new problems like drug shortages. So there's no sign that this is going to be over very shortly.
You mentioned testing. There's diagnostic testing. We're way behind the curve on that, as you mentioned. There's a lot of hope and put in serological testing, which will test for antibodies. How hopeful are you about that?
Not very hopeful at all, unfortunately. So the thing about serological testing is that it looks for antibodies in people's blood that might signify that they have been exposed to the virus and might have some degree of immunity. That's going to be really useful at a population level for working out what proportion of the US has been infected. But on an individual level, there are huge problems. You don't know whether the antibodies you find are actually protective against the virus, and there are very few ways of checking that without more sophisticated tests. You don't know what level of antibodies confer protection. And crucially, if you do antibody testing at an individual level at a point when most of the country has not been infected, your number of false positives, so people who wrongly are told that they have those antibodies, are going to be massively larger than the number of true positives, people who actually have those antibodies. So at this stage, if you do antibody testing, if you get a positive result, there's only a very small chance that you actually have the antibodies in question. And then you have all the social implications, like you're incentivizing people to basically get infected as quickly as possible so they can return to work. And you're creating new forms of discrimination between the immunologically privileged and people who aren't. And I think all of these things mean that this is not going to be an easy solution, and one that we need to consider very, very carefully.
There had been some thought that this might be seasonal in nature, that in the warm weather months, perhaps we'd see a lessening of infections. What's the current thinking on that?
So most of the virologists and epidemiologists I spoke to are not hopeful that that's going to make a substantial difference to the course of the pandemic. It's likely that in the future, the coronavirus may be seasonal in the way that many respiratory viruses like other coronaviruses and influenza are. But for the moment, the world is just full of immunologically naive people. There's just too many people who've never seen this virus before for it to burn through. It's like hoping that the summer will quench that is like hoping that a gentle rain will put out a raging wildfire that still has acres of kindling to scorch its way through.
You write in your article that what's needed is an all hands on deck approach to what's going on. Are you seeing that in the United States?
Unfortunately, no. There are some promising signs for sure. The country's research and biomedical enterprise is working overtime to try and find different types of countermeasures. Certain groups of states are banding together to try and find their own local solutions to how to reopen the country. So all of that is promising, but really what is needed is some massive Apollo program style initiative that's coordinated by the federal government to get our readiness to a point when we can deal with future waves of the virus. And either the administration has no plan or is not disclosing its plan. And in the absence of that, other people are having to make do with their own like bespoke local level measures. Now, whether that's going to be enough, I'm not sure. Certainly, I think that solution will be less than the sum of its parts and will lead to wide disparities across the country.
You're talking from a science perspective, but clearly there are other factors in play, economic and political. How is that going to influence the course going forward?
Yeah, the matter of how to balance health and economy and the influence of economy on our health and our health on the economy is obviously a huge question. Also really relevant, I think, is the successive epidemics that we might see after COVID-19. This surge is over. There'll be waves of mental health problems. There'll be waves of other health problems related to the swamping of the healthcare system, to people having to stay at home for so long and not getting treatment for illnesses that they should have got treatment to. And this is again why I think that this is going to be a long-term problem that we need to start steeling ourselves for now, because it's not just the case that deaths will start decreasing and things will go back to normal. Once we flatten this curve, we'll have many other curves that we need to deal with.
Devin from New York City asked, do you think the CDC's initial recommendations to stop buying masks has affected its credibility? And I'd like to broaden that and ask, where is the CDC?
Yeah, so just very quickly on masks, I think the guidance around masks has certainly changed. I think the idea that we need to preserve them for healthcare workers because they're in short supply and they are most needed on the front lines is absolutely right. And then society is changing how it views masks, not as a way of preventing yourself from getting sick, but as a way of preventing other people from getting sick from you inadvertently. That's a much larger discussion. On the issue of the CDC, I think that the fact that the CDC has been absent from White House press briefings for a long time now is certainly causing problems. And this is supposedly one of the greatest public health agencies in the world, and the one that many similar agencies around the world are modeled on. That's why there's the China CDC, the Nigeria CDC, and yet they aren't in a position where they can provide advice to people at a local and state level who desperately need it. And I've heard from public health experts that they are getting calls from mayors and governors asking them for advice when they would normally go to the CDC. And I think that is going to have a lasting consequence on America's ability to prepare for these kinds of threats.
You say in the article that you wrote this morning that when do we get back to normal is the wrong question. How should we be framing this?
So I think the answer, the way to look at it is, how do we go forward? What kind of new society do we want to craft in the aftermath of this? We know that we're not going to go back to a position where we have mass gatherings, for example, for probably the summer and probably for the rest of the year. So our lives are going to look very different. I think the pandemic has revealed a lot of fault lines in society, vulnerabilities among people who don't have the choice to social distance because they are underpaid in jobs that demand their presence. We've seen large social changes that companies and institutions drag their heels on, like remote working, like proper sick pay, like childcare assistance, that now suddenly are manifesting very quickly in the wake of this big global crisis. So I think there is going to be a lot of tragedy in our future, but there's also a lot of potential for reevaluating what norms in society we perhaps became too accustomed to, and how we can build something that better cares for the needs of the vulnerable and marginalized among us.
Ed Yong, thank you. And check out Ed Yong's new article, Our Pandemic Summer. Great to have you with us. We'll let you get back to reporting on this story.
Thank you.
We do want all of you out there in the audience to be part of this conversation, so please ask your questions using the Q&A function you see on your screen. Try and keep your questions short and concise, and please keep them on topic, and let us know where you're watching from. We'll try and incorporate them, as many as we possibly can. Now let me bring in Ron Klain. Ron is the Executive Vice President at Revolution and was the White House Ebola Response Coordinator in 2014 and 2015. Ron, it's great to have you with us here today.
Thanks for having me, Jeannie.
You are, of course, an advisor to the Biden campaign, and I'd like to talk about politics just a little bit. Obviously, physical campaigning is just a no-go. Can't go out there and kiss the babies and shake hands. Is that going to radically transform the nature of this presidential race?
Well, obviously, it changes how candidates for president and for all offices in America have to campaign right now. They're campaigning digitally. They're getting their messages across by putting out videos and doing virtual events like this event that we're having here for the Atlantic. And so I think it's changing the nature of the campaigns, but I don't think it changes the substance of the presidential campaign. I think we've seen over the past couple of months a pretty clear difference develop between Vice President Biden and President Trump on how they would approach fighting the coronavirus, on what they would do in response to it, on what their ideas are about the public health response, about the economic response, about their styles of leadership. And I think that choice is before the American people very, very squarely. It's a very stark and really sharp choice between these two men and the kind of presidency they would have. And I think that is coming through loud and clear on whatever mediums it's allowed to be transmitted by right now.
But the president has 2 hours of television time, sometimes more, virtually every day at the White House. How does Joe Biden, even through the wonders of digital communication, counter that kind of free media?
Again, Jeannie, I think it's not a question of quantity, it's a question of quality. I think when the president uses that time to mislead the American people about what's happened, to mislead people about his record, to thrash out at reporters, to make almost everyone the enemy except the virus, not sure he's really doing himself any good politically. I know he's not doing the country any good in terms of fighting the virus. With all situations with an incumbent president, he's going to be judged on his record. His record on fighting coronavirus is one of long delays, downplaying it, denying it, eschewing scientific advice, not listening to his public health advisors, and us paying the price for it. A minute ago, Ed was talking about this tremendous gap we have in our country on testing. Why do we have that gap when Korea doesn't, other countries don't? That's because of choices and a failure of leadership that President Trump made. So I think the record's going to speak for itself, and I think that contrast is going to be very, very clear.
The vice president laid out the nuts and bolts of his plan in an op-ed yesterday. It was very nationally focused. You know better than most that this is a global pandemic. Does he have to have a global strategy to deal with this? And does the president need one?
Yeah, so Vice President Biden laid out his plan to deal with the virus in mid-March, March 12th, and people can go to joebiden.com and read it. And that included an approach on global health security. It's something that he and President Obama have been very focused on since 2012 when they first launched the Global Health Security Agenda, and of course is expanded by the Ebola response in 2014 and the ways we built on this. I think, Ginny, this is right. I mean, right now, we in America, understandably, are focused on the impact that this virus is having on us, on our health, on our families, and on our economy. But it has to be seen in a global context. It will do us no good to fight this virus in the ways Ed was talking about a few minutes ago here at home if it rages overseas, because in that case, it's just going to come back. It's an interconnected world. So as we pursue solutions, first and foremost, I think in our political system, those solutions are about protecting the American people, taking care of us. But in the long run, what makes America safe is global health security. What protects us is doing a better job of detecting diseases overseas, isolating them, and responding to them quickly. And it was a failure to have that system in place, a failure to engage the Chinese aggressively enough about that, that is one of the key failures of what happened with the coronavirus.
Was it also a failure of the World Health Organization?
I think the World Health Organization had some things right and some things wrong. And I think that certainly I publicly said at the time, they did not declare this a public health emergency of international concern as early as they should have. They should have done that more quickly. They should have pressed China for more transparency and more answers. And I think that has to be looked at when all this is over. I do think that there are weaknesses in the WHO. One of those weaknesses is really not the WHO's fault. One of those weaknesses is that they're not really a response agency. They are a regulatory agency. They identify problems, they report on problems. But I think one thing that this is exposing, which we also saw back in Ebola, is that when you have a major problem, not so much in China, but as this is going to spread in Africa, throughout Asia, in South America, in poor countries, there is no international resource to go help fight this disease overseas. We are incredibly dependent on NGOs, brave, amazing, fantastic NGOs, but under-resourced, under-empowered, understaffed NGOs. And we're going to see the pinch of this as this disease spreads in Africa and as this disease spreads in other poorer parts of the world.
Are you suggesting that such an organization be formed, and under whose auspices?
Yeah, so back in 2016, I wrote a piece where I laid out the pandemic threat and made 6 specific recommendations. One of those was to create a global white hat battalion. At that time, the idea was put forward by the Germans and to do it under the auspices of the EU. The UN looked at a similar idea, did some of this during Ebola, but ultimately wasn't really that successful with their efforts. We need a capable international response force that has the ability to deal with these kinds of pandemics, particularly in the developing world. And one other problem we're seeing, if you look at the current outbreak of Ebola in the DRC, in Congo, what's happened there is even though we have a vaccine, even though we have all kinds of countermeasures to fight that disease now that we did not have in 2014, the presence of violence there, the fact that responders are getting killed, has really impeded the response. So as this disease moves around the world, there's going to have to be a security component to fighting this disease in unstable areas, in areas with civil conflict, in areas with large refugee populations. It's a combination of a global health response and a security response to protect the people who are victims and to protect the responders who are fighting the disease.
And in many parts of the world, including the United States, there are people who oppose vaccines. They don't want to see them deployed. If that is in fact the solution to COVID-19, how do we get that message across? How do we persuade people that vaccination is a must?
Jeannie, it's a fantastic question. I've said elsewhere that I think the greatest public health challenge we're going to face in this country in 2021 is going to be manufacturing, distributing, and getting people to take this vaccine. Right now, we're focused, understandably, on the science challenge. Can we develop a vaccine? Can we get it tested? Can we get it proven? What will be the prevailing vaccine candidates? And that's an amazing challenge. Ed alluded to this before. The scientific community is doing incredible, historic work on this front. But that's really just the first step. Making hundreds of millions of doses of this vaccine, without displacing the manufacture of other critical life-saving vaccines is going to be a huge manufacturing challenge. And then, as you alluded to, once we get it made, we have to get people to take it. Now, this disease is so infectious, we're going to need a very high rate of vaccine compliance, perhaps as high as 90%, to get the kind of immunity you'd want, the herd immunity you'd want in this country. And to get 90% of the people to take this vaccine, it's going to be a real challenge. It's going to be a challenge in distribution. You know, we're used to in this country getting children to take vaccines and doctor's visits, using school attendance as a way of compelling that. This is going to be much bigger and much broader than that. When we see the level of vaccination rates for the flu vaccine in the 50%, we're going to have to obviously do a lot better. And that means overcoming the kinds of vaccine hesitancy and resistance you're talking about. It means persuasive messages from public health communicators, from non-traditional communicators. It's going to mean an incredible civil effort and civic effort to get the vaccine made, distributed, and into people's arms.
And of course, we don't have a vaccine at this point in time. You're familiar with the health infrastructure and living conditions in other parts of the world. What kind of impact is COVID-19 going to have in Africa, in Central and South America?
Yeah, I think that, as I said earlier, we're living through this here in the US now and really suffering mightily from it. And I understand why we're focused on that. We should be focused on it. That should be our first priority as Americans. I understand that. But as hard as this has been for us, when this starts to ravage countries that have much less advanced healthcare systems, much fewer resources, many fewer doctors, many fewer nurses, even less protective gear than we have, it is going to be devastating on those countries and devastating on those societies. You know, when we fought Ebola in 2014, 1 in every 10 people who died in West Africa was a healthcare worker. And that had a dramatic impact on the ability to fight the disease. It had a dramatic impact on those societies in the long run, because it means other healthcare services are still suffering in those countries years after the epidemic because of a lack of doctors, a lack of nurses. This is not a renewable resource. We can't just instantly make more doctors and nurses. It takes time to replenish those losses, beyond obviously the human toll of that. And so we're going to see really catastrophic impacts in places where this disease becomes widespread in the developing world, certainly until there's a vaccine. And then again, with the vaccine, they're going to have to make literally billions of doses and get it to all kinds of places. Now, the Global Vaccine Alliance, Gavi, has said that they are interested in taking on this project, but it's going to be a huge project.
Ron, I'd like to get to a couple of the questions from the audience, if I could. Ryan Hayden is asking, how does our response change if President is reelected versus Biden winning? What's your response?
Well, as I said before, I think there's obviously, I'm a Biden partisan, I wear that on my sleeve. There's no objectivity here. But I think that there is a big difference between the two men and their approaches. And it starts with their willingness to put science first. Vice President Biden said very clearly that scientific knowledge, medical advice will drive his approach to it. He's impaneled a group of leading medical experts who advise him. He talks to them every single day about updates on the disease and about the policies he's putting forward. And I think that's a big difference at a time when you see the president trying to replace his scientific advisors, announcing that now an economic team will advise him on reopening the economy as opposed to listening to public health advice. I think that difference in terms of a belief in science as the touchstone of the response is one big difference. And then I think a second big difference is a belief in the role of the federal government. President Trump, ironically, both proclaims his unilateral and absolute power to shut and open the economy, but on the other hand, when it really matters in terms of driving this testing solution, driving the collection and distribution of protective gear for our healthcare workers, helping hospitals build responses. His answers, that's a state problem. It's up to the states to get testing fixed. It's up to the states to get protective gear. Vice President Biden's been very clear. He would use the Defense Production Act to take control of the supply chain, to have the federal government oversee the manufacturing of the tests and the gear that we need, and to make sure that's getting to the front lines. So I think those are two big differences between their approaches to this crisis.
Ron, we're almost out of time, but I want to ask you one more question. Bob Smith asked, why has the CDC been sidelined during the coronavirus crisis? We heard Ed Young's thoughts. Quickly, what are yours?
Yeah, I think it's a shame. I mean, I think that the CDC is our nation's leading public health agency. As Ed said, it's really the world's leading public health agency. When I worked for President Obama, we're quite proud of the fact that we helped launch and fund an African CDC. All over the world, countries model what they're doing against compared to our CDC. And so to take this great resource and to put it on the sidelines, I think that's a real shame. I hope the Trump administration will change its approach to that.
Ron Klain, White House Ebola czar under President Obama and an advisor to Joe Biden. Thanks so much for joining us here today.
Thanks, Jeannie.
And now I'd like to turn to a message from Steve Ubel. He is the president and CEO of PhRMA, who is our underwriter for today's event. Steve?
Thanks so much, Jeanne. PhRMA is pleased to be sponsoring today's Atlantic digital event featuring speakers at the front line of fighting COVID-19. I must say one of the bright spots has been to see the entire healthcare ecosystem rally on so many fronts, whether it's the FDA expediting approval of diagnostic tests, or hospitals and frontline healthcare workers selflessly treating those infected by the disease, and policymakers who are acting to address the economic fallout caused by the virus. For our part, our companies are really literally working around the clock on 4 key fronts. First, our companies are partnering with other life sciences companies to enhance our testing capacity. One of our member companies, Genentech, you'll hear from Dr. Lee a bit in a moment, is running thousands of tests on their Roche platform. Our companies are also donating laboratory equipment and supplies. And one of our companies even tapped their in-house laboratory capabilities to develop a drive-through testing center. So testing is one area where our companies are very focused. Secondly, our companies are screening their vast global libraries of existing medicines. These are medicines that have already been approved by the FDA for other conditions to repurpose those treatments for the purpose of treating COVID-19. And there are already more than 300 such trials underway, and many of these medicines are being made available to patients today in the auspices of clinical trials. And there are really 3 key areas that are the focus of much of this research, whether it's antimalarials, antivirals that have been developed for Ebola or HIV, for example, or immunologic agents that are used to try to modulate the body's overactive immune system, which compromises the lung during a respiratory illness. Third, our companies are working to develop new therapies and treatments. One of the most promising areas of focus there is antibody-based treatments. And there are 2 main aspects of that, which you'll hear more about from our additional speakers. But convalescent plasma, where you're taking antibodies from those individuals who've already been exposed and infected but have been recovered, using that plasma that contains antibodies to help those infected fight the disease. The other approach, which is quite similar, would be to genetically create these antibodies, and they would be used as a biologic medicine. And there's very promising work underway on both of those fronts. And then finally, our companies, as you know, are very focused on developing a vaccine. There are now more than 70 programs underway, with several already in human trials. And that's really important. We're going to need a lot of shots on goal to make sure that we find a vaccine that is very effective, given the vast number of individuals who are going to need to be inoculated. And I must say, as you think about those 4 fronts, I am cautiously optimistic that the industry is going to deliver for 3 key reasons. The first is the industry has decades of experience and deep scientific knowledge regarding similar viruses and diseases. So think about SARS and MERS and Zika, Ebola, and our companies are tapping that vast scientific knowledge to address this current COVID-19 crisis. Our companies have also invested for years in cutting-edge technologies that are shortening the amount of time it takes to get from the bench to the bedside, from the preclinical stage to actually having a new therapy or vaccine available to patients. You may recall that during the SARS virus a decade ago, it took almost 2 years to get the first candidate vaccine into human trials, whereas today with COVID-19, as I said, you already have a few candidate vaccines already in human trials less than 2 or 3 months from the first known case. And then finally, as Ron mentioned, manufacturing is going to be a key challenge, and our industry alone has the unique capability to scale and manufacture any new treatment or vaccine. So in closing, I did want to also mention affordability. I must say our industry is keenly aware of what's at stake in this environment and is deeply committed to providing these new treatments and a vaccine, making them affordable and broadly accessible to patients who need them. In previous pandemics, affordability has not been an issue, and I don't expect it will be an issue this time around. So Jeanne, thank you very much. Thank the Atlantic for the opportunity to sponsor today's discussion. I'll turn it back to you.
Thanks again to PhRMA for underwriting this event. Let me introduce now Dr. Brendan Carr. He is Chair of Emergency Medicine at New York's Mount Sinai Health System, and also Dr. Patrice Harris. She is President of the American Medical Association. Thank you both for being here with us today. Dr. Carr, we heard Governor Cuomo say yesterday that he believes that New York may be past the worst of this. Does that match what you are seeing in your health system?
Thanks very much for having me. It does. You know, the thing that is clear about this disease is that it has a very long course, and we have seen a decrease day to day in the number of patients, especially the number of critically ill patients that are presenting to our hospitals across the system. But our hospitals are very, very full because there are so many patients who are still recovering, who are still receiving critical care services or other general medical services.
Do you have the supplies that you need?
We have been very, very lucky. We have had the supplies. Our ventilator utilization never got above 80% or so, in part because we had an ever-growing denominator. You know, there were other guests have talked about the private sector showing up in lots of different ways. It was astounding to see not only people that were ramping up production, but also people that were helping us with the engineering around converting a BiPAP or a CPAP machine into something that could serve as a ventilator.
At this point in time, how many of your employees are testing positive, and how many of them have you been able to test? As you probably may remember, in the early days in New York, we were testing a lot. And then we stopped and were only testing people that were sick enough to be admitted to the hospital. We have only, so sorry, go ahead. I wanted to ask about your employees and
right,
what you're seeing with your doctors.
So we were testing our employees if they were sick enough to be admitted to the hospital. And so just recently we have now been allowed to start to test our employees who are mildly or moderately sick, rather than using their symptoms to dictate whether or not they can come back to work.
And what kind of numbers are you seeing?
Oh, it's literally days that we have been testing employees. I'm sorry.
Dr. Harris, there are thorny questions here for doctors, for nurses, for other health professionals. They have to weigh whether to do their job versus keeping themselves and their families safe. Are they prepared to make those kinds of judgments? How do they make those judgments?
Well, certainly, and thank you for the opportunity to be here. And physicians, nurses on the front lines of this pandemic are exhausted, don't always have the PPE. I'm so glad to see and hear that they have the PPE at Mount Sinai, but of course, across this country, we have to make sure that PPE is available. But you know, physicians went into this profession, chose this profession with some level of risk, accepting some level of risk for infection. But I have to say that there's also an expectation, I've called it an accountability contract, that physicians and nurses and other healthcare workers on the front line have the equipment that they need. And there's been a variability regarding that across this country. That's why in the very beginning, the AMA called on the president to develop, a Marshall Plan, Manhattan Project. You can use whatever analogy works, but we really need an all hands on deck approach to this. And while some areas have the PPE that they need, there's a concern that we don't have that across the board.
Dr. Harris, there are some doctors and nurses who have been disciplined for speaking out about not having enough supplies. Is that the way medical institutions should be handling the situation?
Well, we are hoping and have always had a partnership across the spectrum. And certainly the AMA was quite concerned regarding any nurse or physician being disciplined for certainly speaking what was a known fact, that they didn't have enough equipment. Now, we certainly get that we have our own media policies, at the AMA and institutions do, and those are appropriate. But certainly we do not feel it's appropriate to discipline or punish physicians or nurses in any way for speaking up about what their needs are.
We have some questions coming in. Gary Ricard asks, what have we learned in patient care that saves the lives of COVID-19 patients? Dr. Carr?
We have learned a lot. It's been pretty extraordinary, actually, to see the rapid pace with which we've learned too. I would add one piece that, that is often left out, which is that often in patient care, we mean the clinical side of patient care. The idea that the delivery system would need to respond to something that was not prepared to respond to, not for most people, something that was ever imaginable, needs to be included. Delivery system science and what we have learned about how to effectively care for people is critical and deserves more attention. On the clinical side, this disease met, the American healthcare system, and the American healthcare system did what it does, which is instantly start to function in a learning way and learn and learn and learn. So everything from the stuff that's happening with convalescent plasma, which folks have talked about, certainly conversations around simple critical care interventions, how to ventilate them, how to oxygenate them, how to position them, all of the work around the clotting problems that we're seeing. It's a long, long list of amazing, amazing science that's been happening.
I know that Mount Sinai has been doing some work on the plasma donations. Talk to us a little bit about that and if you're seeing anything one way or another on the effectiveness of that kind of therapy.
Yeah, sadly, too early to know about the effectiveness. But the numbers have been extraordinary. Sinai we were very lucky to have a couple laboratories in-house that got out in front of this very, very early and that had the capability to detect the antibody and then to sort of turn it into the convalescent serum. And it's been infused into dozens of patients at this point in time. And, it is, as anyone sort of who follows this knows, it always feels like you're making headway. It always feels like you're making a difference. And we're always really reluctant until we actually get to the right number of patients and do the math to determine whether or not it's been helpful.
We have a question from Deanne Kassim. She asks for Dr. Harris, what changes to CMS HHS waivers, for example, regarding telehealth, do you hope to see become permanent after this crisis is over?
Well, I think, and that's a very important topic on two levels. First of all, the AMA is and physicians across this country are very appreciative of the work of CMS to expand opportunities for telehealth. Of course, that required loosening some restrictions, even allowing visits via the telephone, because you know what? Not everyone has broadband internet access. Not everyone has an internet data plan. And some folks like my father, who's 86, they're not proficient. And so those relaxation of some of those regulations were very helpful. But here's what I want us to all think. Certainly in the midst of this pandemic, we need to have an all hands on deck approach and do whatever we need. Going forward, after we get around the acute phase of this pandemic, we're going to have to be very thoughtful about the learnings from this pandemic. And so some of the things we should probably continue, and some of the things we're doing right now that are appropriate for the emergency, we should perhaps discontinue. And we are going to have those thoughtful conversations. We're going to have to look at the data and the evidence. I know the AMA will be willing to lead those conversations. So I don't want to get ahead of those very thoughtful conversations that we absolutely have to have after we get beyond the acute phase. And I also want to remind everyone that certainly New York may be on the other side and may be on the downslope, but there are other areas of the country who still may not have yet reached their peak. And so we really need to appreciate, it's not new information that different regions will hit their peak at different times. But again, once we are on the other side of this, we need to have those very thoughtful conversations of what we continue to do and what we don't. Certainly telemedicine and telehealth, very important, but not a panacea. And we will certainly have to find the appropriate role and place for that going forward.
William Fitzharris asked a related question. He's asked, does the U.S. have sufficient medical infrastructure to meet the needs of rural America in the event of serious outbreaks there?
Well, certainly that has been a concern, and that's why, everyone has been physical distancing. I like to use that term because I want to make sure we stay socially connected. But I think people forgot that the main reason we did that, I guess two main reasons. Number one was to slow the spread of the infection, but so the rate of rise, and we wouldn't reach the peak at a moment when it would overwhelm the health system. And certainly in New York, there are assets that we don't have maybe in the rural parts of Georgia where I live. And so we have to continue to look at those under-resourced areas and low-resourced areas, because it would be very easy to overwhelm the resources that hospitals in a rural area that may only have one or two ventilators. So that's why actually social distancing, physical distancing continues to be a piece of that puzzle. And another issue when we get on the other side of this is to look at under-resourced areas, which could be rural areas and sometimes even urban areas, and make sure we have adequate access to health care.
Jeanne, can I piggyback there?
If I could, about racial disparities, which African Americans and Latinos disproportionately infected and dying of COVID-19. We know, or we have heard from medical professionals like yourself, that these populations are more likely to suffer from some of the underlying conditions. We know that they may not have access to healthcare. But is there another factor here? Is there also a distrust of medical institutions and government? And is that playing a part?
Yes, you mentioned the underlying health inequities and the disproportionate impact of diabetes and hypertension, which in this case caused increased mortality in COVID-19. And also another point to raise is that Black and brown people are overrepresented in some of those essential jobs. Not everyone has the privilege of being able to stay home in those essential jobs, and those workers are continuing to go out. And of course, they are continuing to be exposed. So that's another issue. But the third issue is misinformation. I said that the first 2 weeks of this pandemic, I spent my time really not in my role as AMA president, but as a family member and a friend dispelling myths. And a part of that whole issue actually is distrust. I have to say, as the first African-American woman to be president of the AMA, I talked about bringing all of who I am. And I know that personally, not my personal experience, but family members, and that worry and distrust from a history ago, the Tuskegee experiment and other issues that have occurred in this country. And so that's why it's so critical that we make sure that there's credible, trusted sources of information out there for all communities, and we respect the needs of the communities about how to get information, trusted, credible information to the various communities.
Dr. Carr, I have a question for you from George Matthew, who asks, are you prepared for a second surge before and or after summertime? And do you have enough health professionals and resources? Will you be able to retain them through the expected financial losses through the next few months?
Well, yeah, those are three big questions. Are we ready for a second surge? I would ask, of what? In part, of course, we're talking about COVID, but it is eerily quiet in our emergency departments at times because of all the other patients that are not there. So we believe the next surge before the next COVID surge will be all the folks who stayed home with heart failure and emphysema and renal failure and all of the things that are in one way or another going to manifest as an acute exacerbation of their chronic condition. And then there will be, presumably after that, another surge or several more surges. The 1918 flu pandemic didn't end until 1920, right? And so, we don't think we're looking at a couple weeks or a couple months or a surge. We think we're looking at a very long game. And then there was another question baked on there at the end about whether or not, what this is going to do to the healthcare workforce. It is, when we haven't talked about this quite so much during this conversation, but people, this is extraordinarily hard on the workforce. It is wonderful to see the celebration at 7 o'clock at night that people cheer and we feel it, and people send gifts and food and are really, really trying to do all that they can to support. But it's also terrifying. A lot of our employees are living in hotels, are living in apartments because they're afraid of infecting their loved ones, their partners, their children, grandparents that are living with them, and they bring that to work with them. It's not normal to watch people die at this pace all the time, and that is making a huge impact and likely will have an impact on our workforce, as suggested by the question.
Are you having people quit?
Actually, no, I would say. Yeah, I could think of a couple isolated experiences. We are having a shocking number of people showing up and asking if they can help. People that are here because they feel drawn to this. People, some of them saying, "I don't need to be paid. I have a job at home. I just wanted to come and help. Could I take a couple of the overnights so that your guys can go home and sleep?" I mean, it's extraordinary to see the best of people show up.
Dr. Harris, you are actually a psychiatrist. And I'm sure you're well aware of the toll this is taking on the medical profession. What's the long-term impact going to be?
I couldn't agree more with Dr. Carr that we really have to talk about this more. Of course, pre-COVID-19, we had a woefully inadequate mental health system, and I think that's going to be worse, actually, after we get through this. And so we are going to have to make a concerted effort to make sure that, again, the mental health needs of not only our colleagues, but also of the country are met. And so that's a critical point, and we have to begin to talk about that. The other issue, and again, Dr. Carr mentions this, is there's going to be a lot of pent-up demand. People are delaying visits, child visits even, and missing their vaccinations. The last thing we need right now is an infectious disease outbreak on top of COVID-19. So there will be a demand for that. As you are aware, many physicians have either reduced their hours or closed their practices, again, for many reasons. Telehealth is making up some of that, but again, some things can't occur through a telehealth visit. So we will need to be ready, and I even get back to PPE and the shortages of medications. As we open up our sector from large systems to small, we are going to need even more equipment. And another issue that we haven't talked about yet is the shortage of medications. And I was also chair of the AMA's opioid task force, and we've seen some shortage in the ability of some of the medications to treat those who have a substance use disorder. So we have a lot of work to do. Certainly we will all be ready, willing, and able to do that. And physicians and nurses, we are running towards this problem. And I, again, thank all the physicians and nurses and healthcare workers, but we also have to make sure that they are supported now and in the future.
Can I piggyback one piece on there?
Oh, go ahead.
One quick piece. When we think about what it takes to recover from this and what it takes for the healthcare system to be ready for the next, I think we have to, this is a sophisticated audience listening to this dialogue. This cannot be about grant-based bailout programs. This has to be about a decision to include in the fundamental way that we pay for and regulate healthcare, the concept of readiness. It is not a central goal of what we do. We have a just-in-time system, and we have a decision now about whether or not we want to change that.
Dr. Harris and Dr. Carr, thank you both for your insights this afternoon. We appreciate it. We have to leave it there.
Thank you.
And for our final conversation, let's bring in Dr. Levi Garraway. He is Chief Medical Officer of the biotech companies Genentech and Roche that are working on developing treatments for COVID-19. Good afternoon, Dr. Garraway. Do you hear me?
I do. Thank you for having me.
You have some clinical trials underway, some of them, I believe, with a drug currently used for rheumatoid arthritis. Can you give us a situation report? Where are you in that process?
Absolutely. So we have a clinical trial underway for a medicine called Actemra. And as you mentioned, that medicine was originally developed for for example, rheumatoid arthritis. The reason for this, by the way, is that for patients with COVID-19 who develop problems, for example, the pneumonia that can cause respiratory failure and the need for intubation and even death, it's believed that part of the reason why that pneumonia happens, at least, is not the virus itself. It's not continued virus replication, but it's the immune response or the inflammatory response of the patient to the virus that becomes excessive. So the recognition of that led initially several investigators in China and then Italy to test the idea that Actemra, which was designed to inhibit that type of inflammation, or in part that type of inflammation, the thought was maybe that would help patients with COVID-19 pneumonia. And so that led us eventually to start a clinical trial, a phase 3 clinical trial to test whether or not Actemra, together with standard of care in patients who are hospitalized with COVID-19 pneumonia, might benefit. So we initiated enrollment of that study in early April 3rd, actually, so we're actively enrolling. We intend to enroll 330 patients at sites across the US and around the world. And we would expect to have final results from that study in the summer, but of course we will have opportunities to take earlier looks as the data emerges. So we are well underway in enrollment.
Okay, but it's still months away.
It's, let's say weeks at a minimum, and it could be months. It, of course, depends on the time of enrollment and what the data looks like.
I'm curious, because this is a drug that is already in use for certain medical conditions. Is there the potential that there will be shortages for those people who are already using it if it indeed proves to be an effective therapy for COVID-19?
Well, certainly for Actemra and actually all of our medicines, we've been mindful of the importance of supplying the world and maintaining that all through this. So we have taken aggressive steps, as you might imagine, to ensure that we will have enough supply, not just for the surge that could be needed if indeed this medicine proves effective and safe against COVID-19 pneumonia, but also to continue to supply our patients who have rheumatoid arthritis and other ailments that require use of Actemra. So this is obviously an area of top concern, but we have taken a number of steps to ensure supply for the world.
I want to pivot from talking about therapies to talk for a minute about vaccines. As I understand it, there are no existing vaccines for any of the coronaviruses. Is that correct? And does that make this a steeper hill for researchers to climb?
So you are correct. There are no vaccines in existence for this type of coronavirus. Certainly, the needs in this pandemic, vaccines, as you've already heard from others on this program, are a big solution over the long term to really finally conquer this. But that's one prong of several prongs that are needed. Therapies that will attack the virus directly are needed, and then therapeutics that may help people recover or get through the critical care mode if they find themselves in that situation are also needed. So really it's a spectrum of therapeutics and vaccines that are going to be needed to really rid this world of this enormous crisis.
Ron Klain brought this up a little bit earlier, the problems with producing enough of what we need. Is the industry going to be able to ramp up production in a hugely significant way to make sure the medicines that are needed, once they're proven, can get to the people who need them?
Well, as was also mentioned, one of the bright lights, if there is a bright light in this crisis, is the extent to which we've seen the pharmaceutical sector, the biopharmaceutical sector come together and partner not only amongst ourselves, but also with governments and regulatory authorities to do everything that we can to make sure that we are up for the challenge. And so that covers the gambit of clinical trials of medicines, but also the need for supply. So certainly I can speak for Genentech that we are doing everything that we can to ensure that we have the capacity to produce medicines that are needed to fight the pandemic, but of course also the medicines that are needed to treat patients with a whole variety of diseases that continue to get sick that don't have COVID-19. So this is top of mind and a critical need. I am encouraged that we're up to the challenge.
The pharmaceutical supply is largely dependent on ingredients that come from China, come from India. Are some of the therapies and vaccines that we're looking at now also going to be reliant on those countries? Are you convinced, if they are, that we're going to be able to get the supplies we need to produce?
So as you point out, components for both therapeutics and vaccines typically are generated at sites around the world. So supplying any given country, whether it's the United States or any other country, for a pharmaceutical company, it's a global, it's an issue of global supply. So certainly this has been a critically important issue. We've engaged in conversations with our government and other key officials around the need to maintain the global supply chain in order to help patients not only in the U.S. but everywhere. And so it's a very important issue that we are paying a close attention to, and we expect that to be attended to certainly by the administration and elsewhere.
Do you think it's a real possibility that those countries that hold the key ingredients or have the most production capacity will hold therapies and vaccines for themselves and their populations, as opposed to giving the rest of the world access? And might they be so expensive that only the very rich countries will be able to afford them, and poor communities and poor countries will be less able to do so?
Yeah, there are two elements of that. One is about the supply of the medicines, and one is about the cost. Thus far, we have not seen any evidence that elements of the supply chain are being hung up because of stockpiling medicines for local use. And as I mentioned earlier, that flow is of course critical to make sure that local supplies are met. So thus far, we have not seen any evidence of that. The other side, of course, is the pricing, and certainly for us, coming back to, for example, our clinical trial of PhRMA, job number one for us is to make sure that the medicine is indeed effective and safe in the setting of COVID-19. If indeed that turns out to be the case, we will do everything that we can to make sure that this medicine, and really any medicine, can be accessed by the world in a manner that is compatible with getting it out there and meeting the need, the global need.
John Wayland has a question for us. He asked, during this crisis, when they talk about people with pre-existing conditions that make them more susceptible to a bad case of COVID-19, I've heard no discussion about smoking. Is data being gathered on whether someone is a smoker, and is smoking or vaping an issue with the coronavirus? Can you answer that one?
Yeah, so as you might imagine, there is a lot of work happening around understanding the natural history of who are the patients that are most vulnerable to COVID-19, who are the patients that recover without much incident versus those that get much sicker. And there are a number of potential risk factors that have been recognized. The data, it's still early days, so it's difficult to comment with precision on a specific kind of risk factor, but certainly it's well recognized that there are pre-existing conditions, lung conditions, cardiovascular conditions that have correlated with worse outcomes. So certainly we'll be paying very close attention to that as more data emerges.
And another quick question, Kelly Russell asked, it seems like there are two paths: suppress the immune system, or number two, boost the immune system. Are there studies on the latter?
So the short answer is that most of the studies that are ongoing are focused on attacking the virus itself, so impacting viral replication, or on attacking the situation where the immune response to that virus is excessive. So right now, our understanding of what makes people sick, those really are many of the clinical trials are focusing on those areas, but there are a number of questions that are important to ask, including the one that was mentioned. And I think in the fullness of time, we'll see attention paid to the whole spectrum of ways in which that we can help patients either be protected from or recover as quickly as possible from this terrible virus.
And also Gary Rickard asked, does COVID-19 increase the need to accelerate adoption of technologies to have verified and immutable trust in the supply chain? For example, blockchain.
Well, one of the, again, I guess one of the bright spots of the fact that we have this crisis is that we've seen so much ingenuity and creativity emerge around ways of working, whether it's supply chain, whether it's the speed at which clinical studies are done and medicines are approved, that can be learnings that we can take forward, both as we cope with this pandemic and more generally. And so I think that specific supply chain example is one, but there are going to be many learnings that we must incorporate.
And Dr. Garraway, we're going to have to leave it there. Thanks again for joining us today. We appreciate it.
Thank you.
That wraps up this week's Atlantic Event Cast. Thank you to all of you out in the audience for your questions and for watching today. And also thank you to PhRMA for supporting the Atlantic Live's journalism. All of you, stay healthy.